All right, so welcome everyone to the 2021. I hope it's the first of many to come panel discussion for my Minority Mental Health Awareness Month, which is every July, uh, thanks to a woman named Bibi Campbell Moore, who discovered that there were just too many barriers. She's African American, and her daughter had some mental health issues, and it was just a really tough go. And she's an author and just said, okay, enough is enough. She went to Congress and got a lot of support to pass this in 2008. So here we are in 2021, really wanting to stop and pause and pay really special attention to really a very important part of our mental health community. So my name's Elizabeth Carvellano. I work at the LifeLink. I'm new to the clinical team there, but I also do outreach and fundraising, development, and that kind of thing. So it's always my privilege and honor to bring folks like this together in our community to connect us to really hold space for some incredible visionaries tonight. So, and I just appreciate everyone being here. And the Life Link, just real briefly, I have some good news, but Best of Santa Fe came out today, and we did make the top 3 mental health agencies in Santa Fe. So I do just want to say that. And after 33 years, it's nice to get some recognition on the comprehensive services that we offer in substance use, mental health, housing issues, and human trafficking aftercare. So that said, again, we are so proud to be able to hold space for this. And I just want to give a shout out first. I'll introduce all of our panelists, and then we'll start with each one of them. They'll talk for about 8 to 10 minutes or so, whatever feels comfortable, but up to that, about how they see this issue and their experience. And then after that, we'll open it up for questions and answer and dialogue and discussion. So I'm just really honored to have, again, Fred Sandavol here. I mean, anyone in the behavioral health world, if you don't know Fred, you haven't been here that long. But with Fred Sandavol, I think the hardest part of this job for me doing this event was consolidating Fred's amazing life resume into a few sentences. I don't think I did it justice, but I tried. And his wealth of experience and service is just beyond compare. But I'll get more into to Fred a little bit details, but Executive Director of the National Latino Behavioral Health Association. So happy to have Fred here. Yay. And then of course, let's see, maybe just say hi, Fred, so people can see you at home.
Absolutely. Well, Elizabeth, thank you so much. And yes, good afternoon to everybody. I'm excited to be here. And with this group, all I could say is, oh my God, I'm so excited because I want to hear and experience what's about to happen. So Elizabeth, thank you. And I hope you can hear me clearly.
We can hear you great. At least I can. Thumbs up with everybody else. Yeah. Okay, good. All right, good. Thank you, Fred. All right, and then next, we'll hear from, after Fred in order, since Silver is not here at the moment, and we hope that she'll be able to jump on soon, is Adam Green. And Adam works at the Mountain Center and does a lot with networking and venture out. And I'm really looking forward to hearing from them and all their expertise. So you want to say hi, Adam?
Hello, y'all. My name's Adam. I use they, them pronouns, and I'm really honored and excited to be here today. Thank you, Elizabeth.
Okay, and then next we'll hear from, in order, is Cam Bowie. And Cam is a mental health clinician here in our state, and really excited to hear from her point of view. So would you like to say hi, Cam?
I'm going to correct that. I'm not a clinician, but I am a macro level social worker. I consider myself a macro level social worker. I've done care in the past, but not at the moment. I'm Cam Bowie. I actually came to the States when I was 2, straight here to Albuquerque, New Mexico. And I've been here ever since. And it's a long time ago. So I've been here for a long, long time. I'm ancient, so Fred and I go way back. So, but done a lot of work in the MCO field. Um, uh, I am a clinical provider trainer right now for a managed care organization. And for some semesters, I do teach senior level social workers at New Mexico Highlands University. So I'm all over the place. And what I do teach is for mostly students in Farmington.
Okay, well, good. We look forward to hearing more and more as we go deeper into the discussion here. So, all right. So I just invite everyone to be thinking of the questions you might want to ask our panel after we hear a little bit more from each one of them. And feel free to use the chat if you need to, and I'll be managing that. So, all right, let's do this. And I'm going to just introduce Fred a little bit more. Fred's worked as the National Cultural and Linguistic Competency Consultant and Trainer. So he's got this consulting background for a number of years. And now he serves, like I said, as the Executive Director of the National Latino Behavioral Health Association. And this includes overseeing lots of programs like the National Hispanic and Latino Addictions Technology Transfer Center and the National Hispanic and Latino Prevention Technology Transfer Center. So I'm eager to learn more about that. And I'm just gonna let Fred really dive into maybe more of his background and expertise. And really, once Fred said yes to this event, I knew it was gonna happen. And I had the confidence that we had some work to do together. So thank you, Fred. And please take it on from here.
Oh, Elizabeth, yeah, thank you for your kind words. And it's just a treat. It's a delight, one, to receive an invitation. And there's no way one should say no for lots of reasons. And the LifeLink has done incredible work from its inception when it started off with a homeless contract with the Department of Health. And I can tell you what that year that was, 1988. And it has certainly grown since then, and it's actually provided some of the most critical services in Santa Fe County. And there's lots to say about Carol and the work that she's done, Andy, and of course now with the new ED, my colleague there. So I want to just say this, thank you for the invitation. And with 8 to 10 minutes, that means I get to do something I usually do, which is talk fast. But I'll try to slow the speedometer a little bit because I'll just try to summarize some key aspects having to do with National Minority Mental Health Awareness Month. And the reason why is because when B.B. Campbell Moore had approached the NAMI National Board of Directors about our supporting her request to submit a bill for naming this National Minority Mental Health Awareness Month, we said absolutely. And so we got to support that that particular piece of legislation to really bring awareness to the issues that NAMI was very much involved in at the time while I was the National Board of Directors. And we actually at NAMI had developed the first multicultural action center. We developed the first multicultural mental health summit. And we actually created a position to actually help coordinate that work. And we really invested what was necessary to bring to bear what are the issues affecting not only Latinos, but African Americans, Asian Pacific Islanders, and many other groups. And it was the start of, for NAMI, of I think what was really a multicultural health equity agenda. All of that to culminate that I'm glad this month is commemorating her. She was a member of NAMI Urban LA with other colleagues of mine there, and she was a spark plug, and may she rest in peace because it really speaks to the work we all should continue to do through our lifetime. I've been fortunate to have done work at both as a public servant and in city government and state government, and have served in many capacities, both locally and nationally, regionally, statewide, and all of it really largely focused on mental health and substance abuse. So what many folks don't know is I have a sister who suffers from chronic paranoid schizophrenia. So I followed her journey from the inception, because when you're only a year and a half apart from your sibling, you're really like this as siblings in that age group. And so having watched my sister in her trajectory in her life, I said to President Bush during the announcement of the new Freedom Commission here in Albuquerque, New Mexico, that was hosted by Senator Pete Domenici, who for me has always been the policy champion for behavioral health parity in our nation. And he was from New Mexico, and he made a promise that he would pass that bill. And he said that 3 months before he voted, and was the deciding vote on that bill. That is now the law of the land, which is mental health and substance abuse parity in the United States. But having said all of that, what I said to the president was, Mr. President, there's just a couple of things I want to say to you. One is that my sister, who's a veteran, suffers from a chronic mental illness called schizophrenia. It's a brain disease. And what's important, I said to him, was that if people can get treatment, people will get better. But if they can't get treatment, they'll experience what my sister did as a veteran of the US Army. She had 10 years of pretty traumatic experiences. Ironically, she was referred to the mental health center where I was the executive director, called Sangre de Cristo Mental Health Center. So this dates you a little bit here. But we were able to have her in our transitional facility for a year and a half. When she transitioned into the community, she went to a boarding facility, was then a client of the Veterans Administration as a veteran, and she has been on a road recovery ever since. So I watched that trajectory over 30 years, and there is hope, but what really significant is treatment. And we're at a time, I think, in our country where all Americans, all individuals who live here have a right to a quality of life. So when we think about mental health, substance abuse, I know those issues as it relates to Latino populations pretty well. And so we know a couple of things. One is 40% of Latinos who need mental health services don't get them. 80% of Latinos who need substance abuse services don't get them. And so that tells you what the disparity is. But what I'd like to focus on, just as I wrap up, because I know 8 to 10 minutes isn't a lot of time, but is I have always said from the first time I was a county mental health administrator, is that hope is the last to die. And when you're hopeful, you look to work at trying to achieve change. Helping is good, but making change can actually improve our systems. Our systems really deserve providers like the LifeLink and others who provide quality care, because we see how people's lives change. They enter into recovery, they improve their circumstances, they make changes. There's a catalyst, and that's what treatment does for people. Because not getting treatment just perpetuates those conditions and they worsen. And we know the lives of people with mental illness are shortened because of that, right? Their productivity, the damage it creates, and the family should watch that. So as a family member, I've observed that. What I also know as a mental health advocate, we have advocated my whole lifetime as a career professional for 45 years. And it took literally probably 30 years to get mental health and substance abuse parity to become a law. So talk about how long it takes to legislate change, right? But what we now know is there's still more work to be done. And New Mexico, I want you to know, is doing some pretty good stuff. There's some things that New Mexico is doing that very few other states are doing regarding mental health and substance abuse parity. So we want to give credit where credit is due, because as advocates, we should say what's wrong and we should also say what's good, right? But having said all of that, here's a few things to take note of, just very quickly. So what we know about Latino and engaging in mental health services is that we know the disparity, but what is important? Well, what is important, of course, are several things. One is that family involvement for Latinos is very significant. Sometimes that contrasts other views, perspectives about how families should be involved in the lives of adults with mental illness. But family units in Latino communities, it is a significant foundation. So thinking to circumvent that or to not include that or not engage those families actually is detrimental to the mental health and the recovery of Latinos. So it sometimes contrasts other perspectives, but what we know as professionals in the Latino world is family involvement is essential, with a big E and a big S and so on and so forth. The other is the natural support systems in Latino communities are in fact the alternative oftentimes in the absence of getting care. So that means other individuals in their life support systems, friends, relatives, faith communities, other individuals that are out there end up providing support and information as best as they can to help through those crises that the person perennially experiences. But it's a source of support because oftentimes the best advice comes from someone who's like you or says things that you can relate to. It's relevant, and it's also said in a way that's culturally and linguistically appropriate, right? Because it's something you connect to, because culture permeates everything we do. It's what we believe in, it's our values, it's the way we do things, the norms that we believe in. So all of that having been said, there's two things I'll just end with. One is, so peer support is very much an important aspect for Latinos because it's a way of ensuring that the advice, the guidance, and the feedback they get coming from peers is very vital, because we also know that there's such a shortage of behavioral health, Latino and cultural therapists, counselors, social workers, and so forth. Peers can be an absolute powerful source for supporting Latinos who are trying to seek services, how to engage them, how to educate them, and more importantly is how to introduce them into the treatment cycle. Because once people are in the treatment cycle, it disrupts the patterns that have actually caused them the grief and the losses and the challenges that they have. So I'll just kind of end with this, because I think the future has a lot of positive to hold for us. We're in the era of health equity in this country. We now have an administration that is resourcing equity, not just talking about it or saying we should be aware about it, right? We all know what the disparities are, so we're pretty aware, but awareness isn't going in of itself change anything. And right, the good advocates are looking to make changes, and the changes have to do with how do we resource the organizations, the community, the entities that serve Latinos. And oftentimes they're led by Latinos, sometimes they're not, and that simply means they serve Latinos. And we want to ensure that the system of care is adequately resourced to be able to do that. So jobs like mine at the National Latino Behavioral Health is to do what? Advise the SAMHSA administrator, advise legislators. We actually help co-write legislation for Congress, men and women. And so Grace Napolitano, for instance, we've worked closely with her to actually write legislation. So when it goes in, we've already put our fingerprints on it. And it's not because we're trying to let people know we're doing that. We're there to serve our policymakers. We're there to help them bring the changes forward to help our communities across the country. And in New Mexico, we get to do that with the Behavioral Health Authority. Our colleague, Dr. Neil Bowen, he's doing some phenomenal work. Just if you could repeat me on that if you want, He's helping it make possible to get Latino students who go to graduate school or doctoral school to get educational assistance through the work we do. And that means we have actually graduated 97% of our graduate and doctoral students to get a degree in behavioral health. So they go to school in New Mexico, live and work in New Mexico to keep the behavioral health workforce as much intact as possible, because there's such a shortage for all of us from any racial background. We need more behavioral health clinicians. So on a positive note, I would simply say is the hope that I had when I used to say back in the 80s that, hope is the last to die. And what that meant is I was always hopeful that the system could change, but I knew that as an advocate, I had to be in the mud, making the adobes to make the change possible. And that means making the changes at micro, meso, and macro levels. And that means there should be no door closed to any advocate anywhere in this country. And if it is, we know that's a barrier and challenge we have to break down. And so I'm excited because we're hoping that the new administration will invite us at the National Latino Behavioral Association to be an advisor to the SAMHSA administrator as part of a multicultural effort to say, this is what's impacting our communities. But this is what we propose we can do together to help address that. Because if you've been in the field for 10 years, 20 or 30, we can contribute some knowledge and insight to how things can be changed. What we don't want to be talking about are the problems, the disparities. What we want to talk about is what are the changes needed and what resources will make those changes possible. Otherwise, nothing will change in those disparities. And the disparities tell us we have a national crisis in the United States. It is not acceptable. Anyone who accepts that is contributing to the dissonance of the lack of quality care and access to people who need it the most, because when you suffer from a brain illness, your vulnerability is left at the mercy of people who can try to address that. And my job is to bring attention to it. I want to say thank you for the opportunity to share some of these comments. And more importantly is for those who are seeking help, Lifelink is there. There's a treatment locator available at SAMHSA. There's a treatment locator here at the state of New Mexico. Help is there. And we don't just encourage it. When you reach out to a peer, say, will you go with me? Because when you go together, there's a stronger likelihood that the person will engage in the system. So thank you, Elizabeth, for letting me share those comments.
Oh, wow. No, thanks to me. Really, all gratitude to you. And I just, maybe there's some reactions out there that you might want to press everybody, but I just want to, I know this is a live event and pausing is not that great, but I just want everyone just to pause because I know I need to, and just integrate that for a minute and just, you said a lot of inspiring words, and I'm so glad we're recording this because I couldn't take notes fast enough. So thank you, Fred. Uh, yeah, I'm
You're
deeply
welcome.
inspired, deeply moved. Okay. Oh, yes, lots of hearts. All right. Next up, in terms of just taking some time, taking some space to talk about minority mental health, is our guest and next speaker is Adam Green from the Mountain Center, working the program Adventure Out. They are a program coordinator at the Mountain Center, and working with some other, looks like, programs, NMGSA network, and just would like to hear more from you, Adam. Tell us a little bit more about your experience and your what you're doing these days, and I'll let you take the floor now.
Yes, so I work for the Mountain Center, which has been around for 42 years now. And I work for two programs, Adventure Out and New Mexico Genders and Sexuality Alliance Network. And the two programs really work hand in hand. The NMGSAN work focuses on folks ages 13 to 24 who are LGBTQIA2S plus or allied with queer and trans youth. And then Adventure Out works specifically with uh, LGBTQIA2S plus folks who are 18 plus. And so there's that overlap. And my work mostly is with the college age folks and and older. And really, what we do is we try to meet our our participants at their many intersectional identities, and that can include their gender and sexuality, as well as their socioeconomic status and their um, race and other factors, and to meet folks where they are and to build up their resiliency and positive self identity and self efficacy. The information about recovery seems to be all around us, but I think that it's more about getting folks into a frame of mind and heart in which they can take in that information. And so a lot of what we do is community building, communication building, practicing things like consent and boundaries and discussing problematic substance use and supporting folks who may a lot of folks in our community may not be in touch with their families of origin, so supporting folks in finding um, structures to replace that. And for a lot of us, that's chosen family, um, and also engaging in this kind of programming like we do, whether that's when it's in person, it can be uh, adventure stuff like hikes and rock climbing and rafting, which can be a lot of fun. But lately during COVID, we've been doing everything online, and that's been surprisingly effective. Like I am impressed by the number of folks we reached. I don't have the exact numbers in front of me, but I know we had like at least 500 contacts with folks over the last fiscal year, and yeah, it's been interesting seeing how much further our reach is into the rural parts of the states now that we're doing things online. And at first, we didn't know how to necessarily like create those in-person adventure feelings online, but I really do feel like we've found a way to create an affirming space that is worth coming to week after week. So we do a support call that is for folks 18 and up once a week on Thursday afternoons. We also do a social support call for folks 13 to 18 on Friday afternoons. Additionally, we have a monthly tea time online for trans, gender nonconforming, and non binary folks ages 18 and up. And we partner with a lot of other agencies around the state, and and just try to connect with as many folks as we can to let them know that they are of worth, and that their wellness is of worth, and that they are loved and cared for. And I would say, like, the main, if I had to boil down the way I interact with our clients to one thing, I would say unconditional positive regard is what I always try to bring it back to, and just sincerity. We encounter folks at a lot of different points in the recovery process. And we may see the same people through different points in the recovery process, and just letting them know that they're always of worth and cared for by us, and that they can go out and come back, and we're still going to welcome them and affirm them. Um, yeah, I think I think that's enough.
Wonderful. Wow, thank you for that little view into your world and how you're serving, especially through these times and the adjustments that you've made. Great information. And I'll make sure that we have access to the resources that you're talking about. For those who are interested, I'll make sure we want to get those posted. So thank you, Adam. And hope we'll hear more as we get into the question and answer section in just a little bit. And for now, I want to introduce Kambui a little bit more. She does hold a dual master's, MSW, MBA from New Mexico Highlands, as she mentioned earlier too, and 20 years experience in health and behavioral health field. She does the interpreter training she mentioned a little bit, mental health first aid, and the adjunct professor for the New Mexico Highlands University. So very grateful that you're here and excited to hear your point of view.
So thank you again for the invitation from you, Elizabeth, and from Fred and LifeLink. When Fred texted me to ask me, do you want to join a panel, to talk about minority health? I'm like, oh, sure. Not knowing exactly what I was getting into, I was just, whatever Fred does, I'm going to jump on board. I know he wouldn't, let me jump off a cliff or anything. I hope not, anyways. I'm that confident in him that I'd be okay. So here I am. But thank you. I just wanted to tell you a little bit about myself and how I actually got into this industry. So my actually undergrad is in business. I have an undergrad in business administration. So I was actually crunching numbers at a multi-million-dollar health system in Houston at the time. And I just had my daughter. She is now, she just turned 14. And and I was just, thinking, gosh, I'm actually tired of crunching numbers. I think I want to do something I can make a difference in this lifetime of mine, something that I would do to leave a legacy behind. So out of the blue, I actually, without having another job, I moved back to New Mexico because this was my home. So I moved back. I didn't have, and that was during the financial crisis back in 2008, 2009. So I moved back without having a job, was out of a job for 7 months, finally landed a job at the state entity at the time. I was I was hired to be program coordinator for I don't know if you remember, but LifeLink was actually a part of that program. It was called Total Community Approach. And from that, I actually moved up and moved to program director and took on many, many more programs, and actually started managing about $64 million in non-Medicaid dollars with the state. So I was able to see the money that was going to substance abuse and mental illness. And I knew I was being criticized for not having a clinical background in for me to be able to manage these programs. So I went in and I was like, okay, let me do this. I'm going to go get my master's. I was looking for an MBA program actually because of my undergrad, and came across divine intervention or whatever it was called. I went and saw that New Mexico Highlands had a dual master's program in MSW and MBA. So I went ahead and applied for that and started that. So here I am. So that is how I became to where I'm at today. I am actually, a talent multiplier now. I do what I want to be doing out there is I did direct care and I really enjoyed it. The problem with direct care with me was I am an empath. So it took a lot out of me. So I decided, I'm going to go to the macro level. And actually being a program director with the state entity, that's where I met Fred. We were on a committee together, a cultural competency committee together for the Systems of Care grant. So and that's where I met Fred, and I ventured into the cultural competency side. And at that point, I knew where I needed to be. I needed to be where I was able to, because in New Mexico, there is a small amount of Asians or small minority here, but enough that we need somebody or people to be knowledgeable, to be able to address the mental health issues and to be able to have that approach, to be able to approach that population. Because like Fred stated earlier, and being in the direct care, that once you have the rapport with the client, that's when you're going to get your in, especially with Asians, where the mental health industry is very stigmatized. When I got into this industry, even my family members, if you're not a doctor, a lawyer, no offense, Dr. Fung, my cousin, the doctor, is on with us today. She is from North Carolina, contracting from IHS. And but if you're not a doctor or lawyer, you are not successful. You're not doing, and being in the mental health field, that is not something is looked highly at. So I was, I had to make sure that in this industry, I could come and have that presence. So, and, try to, eliminate that stigmatism. I mean, it's not stigma, that stigma with, that you see. So, and, mental health does not discriminate. Everybody has some type of mental illness, some type of mental health issues, one way or another. We have good days, we have bad days. I actually feel, mental health we should have, an annual checkup, just like we do for physical health. Because when you just never know when a mental illness will arise. It could be at a younger age, it could be an older age, but without recognizing or being aware and being educated in that, you will not know or see that. I've had being a mental health first aid trainer, I have had Asian parents come to me and tell me, I never saw the sign. I never saw the sign, that my child would do that. And I go, there are signs. We know in the behavioral health field, there are signs. We just have to know to recognize it and to be aware. And that's what I want to be doing in this field. I think that is my calling, to come in this field to do that, to be able to bring more awareness to mental health and mental health issues, mental health illness to the Asian community, and then being able to, educate providers that are not Asian to be able to approach that culture, that population. Thank you. And I'm still working. It's a work in progress. So I'm keep on chugging. Yeah.
Thank you, Kim. Some powerful words there, and inspirational too. From all three of our panelists, I'm just kind of checking to see, oh, there's Silver. She's not going to make it. Okay. All right. So we'll just kind of wish her luck, and maybe we'll hear from her at another time. So we have our three panelists here, which I'm super grateful for, and wondering, I've got a few questions, but I want to open it up to our participants. If there is a question that you would like to ask one of our panelists or all of our panelists, maybe there's a question you'd like to address all of our panelists and have them answer. So I'll take a second and just open it up to our group here. Just ask you to unmute yourself, and then you can just present your question, or feel free to put it in the chat. Any comments or thoughts? Hey, Greg.
Hi. Good afternoon, everyone, and thank you very much, all three of you panelists. Really appreciate you taking the time to be our panelists today. I have a question for Fred. It's kind of a big question, so you can abridge your answer, Fred, if you want. But as far as the Latino community here in New Mexico, what would you say are the with respect to behavioral health challenges, what would you say is working in New Mexico? What's not working in New Mexico, or what is kind of room for improvement, and what can we do to make that improvement?
Oh, Craig, I can always depend on you to always ask the best questions for lots of reasons. You know firsthand the significance of the question, and I greatly appreciate it, because you know exactly what things have worked, what things haven't worked from your vantage point. But the question you're asking around Latino populations, so there's a number of things that are working really well in New Mexico. So I want to say that just right off the top, because sometimes what happens is the negative of the dark always overshadows the light, right? Somehow we've gotten caught up in disparity so much that, quite frankly, it burdens us. And as it relates to Latinos, in fact, part of the tension, the resistance, the reaction to getting help is because not just the stigma that Cam was talking about, but just imagine this. Just imagine putting yourselves in these shoes, right? Because I have a hard time fathoming it, right? And that's that Latinos rank #1 at this health status. They rank second in death rates, that they rank third in diabetes and chronic diseases. They have a disproportionate rate of overdoses. And after a while, that starts to feel pretty heavy. So imagine you carrying that load when you're the person who's trying to do what? Get help and recover. But everything that's said and talked about is the burden that you're carrying, right? The Surgeon General talks about the burden of disease. While the burden of disease isn't just the disease, it's the burden of the stigma of telling people that they live in disparate conditions, that they have poor health status. The messaging of the mental health system has outweighed their ability to serve us. So the injustice in this is the fact that the system is woefully adequate for helping all of us in our country, including Latinos. So to your question, what are the things that work? Oh gosh, if I were to ask the group today, poll anyone in the state, tell me the evidence-based practice in prevention that was developed in New Mexico for youth suicide, right? I'd love to see the response to that, but I'll give you the answer. So there's an evidence-based practice, and we know to reach that status, that means your effectiveness, your evaluation, your data, your research, your peer reviews, the literature, everything that makes it evidence-based. In other words, you can prove that it works to change an outcome. Well, one was developed in a place called Chama, New Mexico. Natural Helpers. It's a youth peer-driven program to prevent suicide from occurring amongst our young populations. And can we prove it? Sure. When you last read and opened the National Registry for Evidence-Based Practices and Programs, you would have found the program called Natural Helpers listed in there. Developed by New Mexicans for New Mexicans about New Mexico issues. And what was it? It was about suicide. And what did we learn? That the youth peers, and I think Adam and Cam, you can certainly relate to this, is how powerful peers are, right? So it doesn't make any difference what the age group is or what the group is. It's the peers, right? Because the peers oftentimes are the support system that people have. It may be the only support system they have, right? Because the absence of family, the absence of treatment, et cetera, et cetera. But anyway, looking at it as a strength, as an asset, that's a very effective evidence-based practice. We also know that other generalized evidence-based practices work for Latinos, motivational interviewing, ASPERT. And I'll tell you about this one. This is very significant. Cognitive behavioral therapy. It's a standard model of evidence-based practice in the country. So anyone who suffers from depression and anxiety will oftentimes be seen or treated by a therapist who was trained in that area, that model. Awesome, perfect. We want people to get help, right? In Latino, what are the three big mental health and issues, right? Or behavioral health issues? Depression, anxiety, and substance use. Okay. So, but then imagine doing what? Putting all three of them together in the same person, right? Very common. Because what's happening is all these things are interacting concurrently and at different volumes and intensities, but that approach has been very effective. Well, it's something that happened as part of one of our research studies. We found that not only did that work, because that's already evidenced, but what we found was an organization that served mostly Latinos in a community of 80% Latinos, and they did a cultural adaptation because the program was not designed for two kinds of areas that need attention: marital discord and trauma. So before trauma became kind of the headline that it is today, a group in El Paso, Texas found that with the adaptation that they did, that guess what? With the approval of the developer, they were able to address the issues that were most commonly experienced by the Latino communities in that community. So there's another example. Cognitive behavioral therapy is used extensively here in New Mexico, but the adaptation isn't. So there's one that would work because the model works, but here's because the adaptation was done very appropriate to New Mexico. Because we have long-standing chronic experiences of trauma, and then now today they're adding yet another label to what our conditions called adverse childhood experiences. After a while, that labeling isn't any different than stigmatizing. What it does, it doesn't give me a lot of hope, right? But the models that do work, we should need to continue to do more of. Telehealth is an effective tool. Now we're starting to also see evidence of the use of interpreters. Hooray, right? In a state that, guess what? 40% of the population speaks another language other than English: Vietnamese, Navajo, Keres, Tewa, Towa, Tiwa, and of course Spanish. So it's like, oh my God, you're responding to our cultural and linguistic needs. How wonderful is that? We'd say, let's meet people where they're at, but what's happening is we're not meeting people where they're at because we don't know enough about how to do those interventions. Our job at NALBA is to help individuals and organizations develop the capacity so that they can feel they're growing to understand how it is that the needs of Latinos can be met. So those are just a couple of examples, right? And I would just say your question is spot on, because what is needed, and I'll say this and I'll end right here with this response. So one would say is, wow, well, that's good to hear. But of course, you don't have folks that maybe aren't necessarily trained in how to do a bunch of other evidence-based practices, but we're going to release here within the next month an evidence-based compendium of approaches that work in Latino communities. And it'll come with a guide so you can then help identify Latino needs and what evidence-based approaches would work for that population. Because guess what? There are so few of them. And one would say, well, why just talk about the few of them? It's because of what is called institutionalized racism. In the year 1999, the Surgeon General found a study, and what did he find? That all the millions and millions of dollars that went into research, of the 10,000 clinical trials that were done amongst the research centers, they found that only 500 Latinos were part of those clinical trials out of 10,000 participants. So think about this. There were 0 Native Americans. There was 1 Asian Pacific Islander out of 10,000. Okay, so just I want you to put perspective. Today's programs are a reflection of what the research helps produce in terms of developing programs to serve communities. While if you don't have research funding going into those populations, and they're the ones with the highest disparities, talk about a big disconnect. So the era of health equity can fix that, right? So when our colleagues in the LGBT community, they can finally have what? Programs that were designed, normed, evaluated based on the needs that are unique to that population by researchers who in fact are, guess what, from that community. And guess what? They have reviewers that are from that community, because guess what's happening is you can't combat racism in institutions unless there's an equal representation of the groups that benefit from public resources. So that's the change that we're after in this country. If anybody's wondering what the heck I'm talking about, if you really want to demonstrate what a democracy looks like, now let's work at this together at Health Equity Agenda, because when B.B. Moore Campbell was talking about her illness in the African-American community, I can tell you what, 80% of those African-Americans she was talking about were people in California who were in the jails and detention facilities getting mental health care in those institutions. And because our system has actually failed us all, and I'll say this to the president, because it's good for them to know the truth, right? We want fact-based information, and we can back it with the science. So I hope that answers the question a little bit, but there's so much stuff that we're doing that's great. And there's some things that we're not doing well, and I'll just tell you one example of that. Our state and every state in the union is doing a very poor job. I'd give them anywhere from an F to a D, D plus maybe, and some C minuses around adopting the culturally and linguistically appropriate services standards. It's a requirement, and most organizations kind of look the other way, don't talk too much about it, and hopefully nobody will ask about it. So this is a fact. I think what's important is let's just call it what it is, but let's help organizations then adopt them to learn how to implement them, support them in doing that. We can't achieve health equity by criticizing our colleagues. The behavioral health professionals, bless your hearts for the work that you do every single day. I've been in your shoes. I've been at 3 a.m. crisis calls. I've helped save people's lives, and I've had my own life threatened. But the point being is this, is let's always remember that the people who are in the front lines, the behavioral health practitioners, bless your hearts. I mean, all I could say is without you, our families would be suffering even more so. So I hope that helps to just kind of give you a flavor, but look us up at www.nalbo.org and look at all the good stuff we're talking about, because a lot of what's going on in New Mexico can be found there. So thanks, Craig.
Oh, thank you for that, Fred. Yes. And I think that's a great question. And I want to spend some time just asking Adam kind of a similar thing. Like, what do you think is working well for the LGBTQ? And I know you added some things that I'm curious about. And what do you feel like we need more support with?
Yeah, so LGBTQIA2S plus. So um, that's the current acronym, and the plus is for what is going to come next. And what is working well is, well, like Fred said, peer support, like social support from persons and their peers seems to be the thing that is working the best. Um, as well as just a sense of connectedness to resources, and a set of we've been teaching a lot of like somatics and regulation and grounding tools, and the more I get into that, the more I feel like, gosh, we should be teaching this to everyone from a very young age. But it's interesting working with the same folks week after week, and hearing back from them which things work for them and when things begin to work better. Um, and yeah, being able to practice skills together and then send folks out into the world with those skills, in their pocket if they need them, with a variety of different tools, because not everything works the same for everyone, right? Um, what is not working for my community is trying to access care and meeting so many barriers. Uh, a service provider may think that they are LGBTQIA2S plus affirming, and then you call to make an appointment and the staff misgenders you, or maybe that doesn't happen, but you get to the place and the forms you have to fill out don't have fill in the blank questions that allow you to express your identity accurately. Um, so yeah, I guess what's not working is a lack of training, I guess, and competency among care providers. I mean, there are some good ones, don't get me wrong, but I do hear a lot of harm uh, being done by underinformed care providers, and I've experienced that myself as well.
Are you aware of any trainings available right now online or, around getting the behavioral health
Well,
field? Mhm.
the Mountain Center offers several trainings. I I don't have a flyer like ready to show y'all right now, but I can send you that information, Elizabeth, if you want to send that out. Sort of like a menu of trainings that we offer. And we have been working with we worked with a counseling center in Albuquerque, and a doctor's office in Santa Fe. So we have been doing this all over the state for the past year. Um, yeah, I'll send that information to you, Elizabeth.
Thank you. Very valuable. I mean, I think, I heard what you're saying. It's like, we just need to really continue to stay informed and educated and engaged and really embrace um, all the wonderful things that are happening in terms of greater awareness and the diversity of our communities. So thank you very much. And looking forward to getting that information from you that we can distribute. All right. So in the last couple of minutes, Cam, can you say a few words about what you think is going well and what might be challenges that we should be aware of?
Yeah, sure. I think with the Asian the community here, we've had some strides. I mean, there I've seen there are more practitioners, there are more providers that are Asian, there are students that are becoming providers out there, and that's a plus. Just having that population, and then also, a lot more people are having the conversation. Approaching others and asking and meeting the client where they are. So it's been been some strides being made, Of course, there are different levels of acculturation, different levels of assimilation, that in some of the clients. So it makes it a little bit more difficult to be open to treatment. But other than that, all we could do is be open and, let them know that there is services if they are needed. So I know New Mexico Asian Family Center has been doing a lot of work in that and advocating. And like Fred said, whenever I get a chance, if someone needs to go to the doctor or needs to go into an appointment, if they're hesitant to go, I'll say, I'll pick you up. I will take you. And they feel a lot more at ease. So that has actually helped a lot. And I'm hoping that I could get, others to do the same when that is, because, the language barrier is huge. Just imagine you going to another country and not knowing the language and going to a practitioner and then and above all, telling them your problems, how difficult is that? So just, I think just providers having that openness and understanding that moment to pause, and using, those class standards when they need it, those interpretation services when they need it and and make it available. That would be really, really helpful.
Pam, are there any resources we should know about that you suggest if people are interested in discovering more and exploring more around some of these, even the interpretive services that you're talking about?
I know UNM, when you go to UNM, they do have interpreter services there. They actually have a Vietnamese interpreter and other Asian for other Asian cultures also. So they are big in that. There's some providers that do, I know Presbyterian Medical Services, they do use the interpreter services that are through the phone because they have to have that through the Joint Commission. But I think some smaller providers, it probably is a little bit more difficult. But I think, just making it aware that that is a client's right, I think it makes it more that, that needs to be utilized more and more often. And I think that starts at the top, trickling down.
Yes.
So.
Well, thank you for that. And, the inspiration and the reminders for accessibility that, really mental health, really reducing those barriers is, hopefully eventually 100%. And I agree with Fred that we want to keep the hope and stay focused on what's going right, but also being aware of the climb we have ahead of us, to create that
Yes.
quality. So.
Yeah, and physical health and behavioral health go hand in hand as the mind, spirit, and body. If the mind is not well, the body is not either. So we have to keep that in mind to treat the whole body.
Yeah. Well, thank you. It's a wonderful topic to end on. I know even what's in the news these days with people like Simone Biles and coming out of the Olympics, reinforcing the importance of mental health as a priority over a gold medal even. So I think that's an incredible message. And what you said, that physical health and mental health really, they're just, as soon as we can get those with equal credit, then maybe we're onto something. But I also liked what Fred said, if you can get people into treatment, they can get better. And so I know that what I'm going to take with me is what are those barriers and how as a community member can I start really looking at getting people of all communities into treatment. And yes, so thank you everyone. This is an hour was not long enough, obviously, and we'll maybe do this again. Any thumbs up if we should do this again? I think these community discussions are just so valuable. I feel just being new into this field that it just gave me some energy tonight. I feel just a differentness in my cells. So I thank you, Fred, deeply, and Adam. Wow, thank you. Just meeting you. I know there's more network to be doing. And Cam, I think this is all just the beginning, hopefully, of continuing these very crucial conversations. And thank you from the Life Link for everyone participating. This will be online. I'll post this. And thank you for everyone who participated on Facebook. Appreciate your connection. And I think that's going to be it, everyone, for our first Minority Mental Health Awareness Panel discussion. More coming soon.
Thank you, Elizabeth, for organizing this. Awesome job.
Yeah, thank you, everyone.
Thank you. Thanks, everyone. Bye.
Bye.